Diphtheria is a bacterial infection that has become rare in countries with routine childhood immunization programs, but it remains a significant health challenge in parts of the developing world. Despite the global decline in cases, it's crucial for healthcare providers to recognize diphtheria, especially when diagnosing acute laryngeal infections in children, those traveling from endemic regions, or individuals who are unvaccinated. The primary causative organisms in diphtheria are toxogenic strains of Corynebacterium diphtheriae and Corynebacterium ulcerans. The early symptoms of diphtheria, such as a sore throat and general malaise, appear due to the direct effects of the bacterial infection, while later symptoms result from the release of the exotoxin. Symptoms typically begin 2 to 5 days after exposure. Initially, diphtheria presents as pharyngitis, with a sore throat, fever, and malaise. On examination, a key sign is the presence of a characteristic greyish pseudomembrane over the pharyngeal tonsils. This pseudomembrane consists of necrotic tissue, bacteria, and a fibrinous exudate. It can cause bleeding if removed too early, but may separate more easily as the disease progresses. In some cases, swelling of the neck, often called a bullneck, can occur due to cellulitis and swollen lymph nodes. Diphtheria can extend to the larynx, worsening symptoms to include dysphagia, severe toxemia, and a distinctive inspiratory stridor. The characteristic barking cough can be exhausting and, in severe cases, diphtheria may lead to acute airway obstruction, which can be life-threatening. Additionally, the exotoxin released by the bacteria can cause severe complications, such as toxic myocarditis in the second week, which can be fatal if untreated. Peripheral neuropathy, like palatal paralysis, can also occur, leading to difficulties such as nasal regurgitation of food and altered speech. Timely treatment is crucial to managing diphtheria. This includes early administration of high-dose benzylpenicillin and antitoxin, typically ranging from 10,000 to 100,000 units depending on the infection's severity. The key is to administer antitoxin quickly, as it cannot neutralize toxins already bound to body tissues. Therefore, clinicians should base the decision to use antitoxin on clinical suspicion without waiting for microbiological confirmation. Managing the airway is also essential, and it can include removing the laryngeal membrane, providing oxygen and humidified air, and using endotracheal intubation or tracheostomy if needed. Systemic steroids may help to reduce the need for such interventions. Bed rest is strongly recommended during the recovery period to minimize the risk of myocarditis complications. Early diagnosis and a swift response are critical to improving outcomes for patients with diphtheria. Vaccination remains the best defense, making this rare but serious disease a crucial reminder of the importance of immunization programs worldwide.